Hello and welcome to another Facebook Live broadcast with MedStar Georgetown University Hospital. My name is Michelle Carter, and today I'm joined by three of our expert and fellowship-trained orthopedic surgeons who specialize in our adult and pediatric sports medicine and shoulder care. Today we'll be discussing common types of shoulder and sports injuries, as well as treatments and procedures that can get you back to the activities that you love. Our shoulder and sports medicine service at MedStar Georgetown is part of the MedStar Orthopaedic Institute. MedStar Orthopaedic Institute has 50 orthopedic surgeons and 20 locations throughout the Washington, D.C., Maryland, and Virginia areas. So I'd like to start by welcoming our physicians. We have Dr. Weasel and Dr. Ryan we have Dr. Brent Weasel and Dr. Ryan Murray right now. We will have Dr. Postma momentarily, but at this time, thank you very much for joining us today. If you'd like to learn more about our shoulder and sports medicine expertise at MedStar Georgetown, stick around, share this link with your friends, give us a like to let us know that you're watching, and if you have any questions that you'd like to share to our panel, please share those in the comment section below this video. So before we begin, I'd like to give our physicians a chance to introduce themselves. So Dr. Brent Weasel, I will turn over to you right now. Could you share a little bit more about yourself and the work you do here at MedStar Health?
Sure. Thanks for hosting this. And my name is Brent Weasel. I'm an orthopedic surgeon here at MedStar Georgetown University Hospital. I grew up in the Washington, D.C. area, and then did my training up at the University of Pennsylvania. And I've been back here at Georgetown for about the past 15 years. I am a shoulder and elbow surgeon, so I take care of almost entirely shoulder problems in my practice at this point. I do a lot of rotator cuff surgery, shoulder stabilizations, and then a fair amount of shoulder replacements.
Well, thank you. Thank you very much for joining us, and thanks for your time. At this time, I'd like to turn to Dr. Ryan Murray. Could you also introduce yourself and tell the viewers about the work that you do here at MedStar Health?
Of course. Thanks so much for putting this together. My name is Ryan Murray. I am also an orthopedic surgeon here at MedStar Georgetown. I originally am from Connecticut. I came here for med school and then stayed on as a resident. And then left for 2 years to do a fellowship, first in adult sports medicine, and then a second fellowship in pediatric orthopedics. And most of my practice now is tailored toward the care of sports-related injuries in adults and in a subspecialty area of kids and adolescents, which is a particular area of interest of mine. And I'm looking forward to talking more about it.
All right, well, thank you both. Let's dive into some of our questions. So first, I'd like to talk about what some of the common sports injuries are that you see in adults. So Dr. Weasel, could you talk about common shoulder sports injuries that you see in your practice?
Sure. I mean, I would say the two most common sports injuries we see in the shoulder. In younger patients, we see a lot of shoulder dislocations. So that's where the ball comes out of the socket in the shoulder joint. And then in sort of patients in their 30s and beyond, which make up a lot of athletes these days, the most common injury we'll see is problems with the rotator cuff.
Thank you very much. Dr. Murray, could you talk about pediatric and adolescent sports injuries that you see?
Of course. So, pediatric sports injuries are not dissimilar to adult sports injuries in terms of how they occur. The difference is in growing kids, sometimes the injuries manifest differently, whereas adults may have soft tissue injuries. Pediatric athletes sometimes can sustain fractures in the same area, oftentimes through the growth plates around the knee or the shoulder, which occur by the same mechanism, but manifest as a different injury with a little bit different treatment. And of course, pediatric and adolescent patients can still have the typical sports-related injuries, including shoulder dislocations, like Dr. Weasel said, and Dr. Postma, I'm sure we'll talk about some of the ligamentous and soft tissue injuries that can occur in the lower extremity that can also happen in kids. There's some considerations in terms of treatment, which I think we'll talk about later.
All right, well, thank you, Dr. Murray. And that's a good segue to welcome our other speaker for today. We have Dr. William Postma on the broadcast as well. Welcome, Dr. Postma. We're talking about common sports injuries in adults. Could you share more about the kinds of injuries that you see pertaining to the knee and hip?
Sure. Yeah, thank you for having me. So yeah, I mainly do perform hip and knee surgeries with a focus on anywhere from adolescent patients, roughly 15 and above, to the weekend warrior to around 60. I would say a lot of the stuff we see is just overuse injuries, and most of the things that we see can be treated without surgery. Some of the common things we do see, which are surgical, are tears in the ACL, tears in the meniscus. Ryan and I both treat a lot of cartilaginous injuries around there, which are more chronic. For the hip specifically, I do a lot of hip arthroscopy. I see a lot of hip impingement, which we'll get into that a little bit later. But so hip pain, and I'd say most of those patients are roughly 18 to probably 45. Once you get past 45 or 50, and you no longer have hip impingement, most of those patients will have arthritis, and that's not something that I typically treat. But most of what we do is, despite us being orthopedic surgeons, I would say most of the things we do can be treated without surgery, although obviously there are exceptions to all that.
Okay, that's reassuring to hear that some things can be treated without surgery. Seems less invasive to me. So thank you very much, Dr. Postma. Dr. Postma, could you also talk about ACL injury? Could you describe what that type of injury is and what are the common signs of an ACL injury?
Yeah, sure. I got a little model here if we can use too.
Oh, great.
See that. So there's four main ligaments in the knee. The ACL, which is seen right here, is sort of it's the main one, and what it does, it prevents the forward motion of this bone on this bone here, and it also provides rotational control of the knee. So it's an injury that commonly occurs mostly occurs in athletes, and sometimes you can see it from car accidents and things like that. Most of it occurs in cutting and pivoting athletics. The common ones we typically see are in the younger population, obviously American football, soccer, basketball. And we do see a decent amount in, I wouldn't say the older population for us, which are the sort of the weekend warriors. We see it commonly in pickup soccer, pickup basketball. Skiing is a big one that we see. It's there's not a whole lot of skiing around DC, but a lot of people around DC ski out west or go elsewhere. So in December, January, February, we see a lot of skiing injuries out that. But ACL is, when you have the injury, it surprises people. You don't really need an ACL for walking around. You don't need it for working out and sort of straight line activities. You do need it for cutting and pivoting things, but it's typically something we do recommend surgery for in order to reestablish the stability of the knee and the health of the knee, but it's not something you absolutely have to have fixed.
All right. Thank you very much for clarifying that. So I'd like to turn to Dr. Murray at this time and talk about the meniscus tear and meniscus injury. So you, Dr. Murray, could you share what a meniscus tear is? That's a mouthful of a word, or a meniscus injury, and what are the common signs of a meniscus injury?
So the meniscus is there are two in each knee. They're cartilage structures that are essentially like shock absorbing cushions between the bones. And the meniscus can be injured in essentially two ways. Commonly we see meniscus tears associated with ACL injuries or traumatic injuries. And the other way you could see it is over time, as people develop some cartilage wear or early cartilage, changes associated with early arthritis, you can get some meniscus tears as a result of that. And so in those patients, commonly people present with either pain along the joint of the joint line of the knee, or commonly problems doing things like squatting or twisting activities that can cause pain in the knee. Very seldomly, but pretty classic is people who have kind of a mechanical, they can't extend their knee all the way, or they feel their knee gets stuck in a certain position. That can sometimes be related to a meniscus tear as well. The treatment of meniscus tears, depends a little bit on why they occurred. And, certainly in the setting of a ligamentous injury, like an ACL tear, we oftentimes, if we're doing surgery for that, we'll address it at the time of surgery. However, in isolated meniscus tears, there are some different non-operative treatment options, such as rehabilitation or injections, that can also help manage the symptoms. But the goal in treating an isolated meniscus injury would be to manage the symptoms, rather than necessarily going to try and fix something. It's a matter of getting people feeling better.
All right. Well, thank you, Dr. Murray. Dr. Postma, could you share what are the treatment options available if someone does sustain a sports injury like an ACL or meniscus injury?
And so ACLs, for the most part, the treatment option is surgery. To be honest with you, that's what's going to get you back to the things you want to be doing. If you did treat it non-operatively, and there's some downsides of doing that, but you could try physical therapy. The problem with the ACL is the ligament itself, it doesn't heal on its own, and so there'll be what we call micromotion in the knee if you don't fix it. And so that micromotion, while sometimes the patient feels it, sometimes they don't. If the patient feels unstable, just with everyday activity, then you need to go ahead and fix it regardless. But the micromotion is what can chew up the meniscus over time. To Dr. Murray's point, and the meniscus, the whole point of the meniscus is protect the knee against, protect the cartilage, the hard cartilage that covers our joints, protect against arthritis. So if over time the meniscus gets chewed up, that predisposes you even more for arthritis. And yeah, that's one of the other reasons, other than to fix the ACL, other than just providing the stability so they can go back to whatever they want to. But we could talk, I could talk for about 2 hours on just an ACL injury, but I'll spare you. But for the most part, the treatment is a reconstruction where you drill a couple holes in the bone, you basically pass a graft where the ligament used to be, and then what happens over time is your body forms a new ligament over that area. And that's still considered the gold standard. There is something called ACL repair, which is a newer, it's an old but newer version of an older technique. We went away from repair 40 years ago because the results were pretty poor, but some of us have kind of looked back and found some patients where if the ligament sort of tears directly off the bone up here, whereas that's not where most occur right in the mid substance. But if it occurs directly off the bone, you actually repair it. And that is something that I do, it is something that Dr. Murray does as well, but it has to be the right patient population. But for the most part, you're doing a reconstruction. And I'll let Ryan talk about treatments for like surgical treatment for meniscal pathology.
Yeah, just to add to that, I would say that most of the time in the setting of an ACL, if someone has a meniscus tear, if the meniscus tear is toward the periphery or the outside part of the knee near the capsule, we'll try and repair that meniscus. Historically, I think a lot of meniscal tears were treated with excision, but now we try and preserve as much of the meniscus as we can with some technology that allows us to repair the meniscus with sutures, and retaining as much meniscal tissue as possible is probably the best thing for the long-term health of the knee. However, some tears, if it's a more chronic tear or one that is not amenable to repair, we'll resect part of that meniscus, called a partial meniscectomy, and that in that we try and minimize the amount of meniscus we take out while getting rid of the pain caused by that unstable tear.
All right. Well, thank you both for sharing your response to that question and explaining that process. Right now, I'd like to talk about shoulder pain. So, Dr. Weasel, what are the most common causes of shoulder pain? I believe you're muted, Dr. Weasel.
Sorry about that. I was trying to stay quiet while they talked about the knee. Now that we're talking about the more important joint, the most common causes of shoulder pain really kind of change as you change in age. So in younger patients, certainly those under 20, and really for the most part under 30, what we see is a lot of shoulder dislocations, and typically with that, they'll have a tear of their labrum, which you can sort of think of a little bit like the meniscus of the shoulder, in that it's a rim of fiber cartilage that goes around the socket to help make it deeper and help keep the ball in place. And then as patients start to get in their 30s and beyond, we see a lot of tears or injuries to their rotator cuff. And then starting in the sort of 50s and 60s, we'll also see patients start to present with arthritis, which is wear and tear of the joint and the cartilage surface of the joint wearing out.
All right. Now, Dr. Murray, how is a shoulder dislocation treated differently depending on the patient's age? We talked about different age ranges of the patients. How does that differ?
Shoulder dislocations are common in younger patients. The things that most commonly are associated with shoulder dislocations are activities like contact sports or sort of high level competitive sports. And so the younger population of people, adolescent and early 20s and 30-year-old patients are the ones that most commonly have shoulder dislocations. And when it comes to treating shoulder instability, the acute management is the shoulder comes out, it needs to be put back in. Sometimes it goes back in on its own. Sometimes someone has to manipulate the shoulder back into place. And then the follow-up for that, the treatment for that depends on sort of the activity the person participates in, the sport of interest, and how their shoulder feels. I think generally the first time a shoulder comes out, you can try and rehabilitate that and non-operatively manage it, unless there's some type of unique finding that changes that treatment. But as shoulders dislocate more than once, the likelihood of it recurring is higher. So the younger the patient and the more dislocations, the more likely they are to sustain subsequent dislocations. And that's why oftentimes if someone has a second dislocation, we'll talk about stabilizing their shoulder with them to prevent them from recurring, because each time a shoulder dislocates, there's more damage to the bone and the cartilage and the soft tissues around the shoulder. And so you want to not only keep their shoulder stable so they're relatively comfortable and pain-free and functional, but you also don't want to have those changes happening on a chronic basis. So in general, treating a younger patient with a shoulder instability problem is typically based on how likely they are to recur, or if they recur, because it's generally a problem, as Dr. Weasel said, of young people, and so they're more likely to recur.
Okay, thank you very much, Dr. Murray. Turning back to Dr. Weasel again now, could you share more about the rotator cuff? Could you share what that is and the treatment available for rotator cuff injuries?
Sure. So, I mean, we talked here a fair amount there just about shoulder dislocation. So let me kind of give you a model here. So the shoulder is this ball and socket joint right here. And the reason we see a lot of shoulder dislocations is because the shoulder, more than any other joint in the body, has the biggest range of motion. So that you can sort of think of that as a golf ball sitting on a tee turned on its side. So that makes it very likely to come out of place, but also allows it to move quite a bit. And so in order to help hold it in place, you have that labrum that we sort of mentioned earlier, which is a rim of cartilage deep inside here on the socket. But the other thing that really holds the shoulder in place during day-to-day activities is your rotator cuff. And so what the rotator cuff is a series of 4 muscles that start here on the shoulder blade, and they come out and they make a cuff around the ball here. And they basically, when they fire, they help compress this ball into the socket. And then the other thing that they let you do is let you raise your arm up overhead. But we evolved from creatures that walked on all 4 legs, and so because of that, the shape of our shoulder blade puts a fair amount of stress on our rotator cuff as you lift your arm up overhead. So there's this bone here called the acromion, and your rotator cuff, the top part of it, runs underneath that acromion. So when you lift the arm up, you often put some pressure on the rotator cuff here. And so that's why as we start to get older, and I don't mean terribly old, I mean sort of 30s and beyond, you'll start to see a lot of wear and tear in the rotator cuff. We know that to some extent that's a normal finding. So if you get an MRI scan to look at somebody's rotator cuff in their 60s, about 50% of them will have a rotator cuff tear. And by the time you get to be 80, about 90% of people will have a rotator cuff tear. But if it does start to bother people, then it can be a problem. And treatment for that can range anywhere from physical therapy to help strengthen up the rotator cuff muscles here in the front that will actually help bring the ball down a little bit and make some more space for the top muscle here over up top underneath the shoulder blade. To if they have a tear of the rotator cuff, which is a hole in it right here, then sometimes you've got to do surgery where you go in there and bring that back where it's supposed to go.
All right, thank you for that demonstration, Dr. Weasel. Now we've talked about meniscus injuries, knee and shoulder pain and rotator cuff injuries. I'd like to talk about the hip. So Dr. Postma, could you share what a hip impingement is and how does it show up? How does it present in the body?
Sure. Now really the most important joint, Dr. Weasel. So hip impingement. So this is a model of a hip. So a hip's a ball and socket joint. Here's your ball. Here's the socket. With a normal ball and socket joint, as we rotate up, the ball stays in the socket. It doesn't really contact the socket. With hip impingement, it's when either the ball right here has an extra amount of bone here, or the socket comes over too far. So if the socket comes over too far, when it flexes up, that ball hits that socket along the rim. And along the rim is where you have the labrum. And probably one of the more common places to see the impingement is actually on the ball part of the ball and socket, not the socket, where we have a buildup of tissue. So let's just take this piece of paper right here. And then if this, instead of the socket being round, you have this piece of paper right here, which makes it more of an oval shape. And so when you flex that hip up, you have an oval shape trying to articulate the round shape, and that paper is going to hit the side right there. So that's going to cause the impingement. And around this is just looking at the socket. Around the socket, there's, I don't have it on this model because it's just a bony model, but there's this big thick rubber band that goes all the way around the socket, forming the labrum. And so the labrum is what gets torn with hip impingement, and that's what causes the pain patients will have. But it's the shape of the ball, predominantly, or the shape of the socket, that predisposes the labrum to injury. So patients most times will present as pain in sort of the front of the hip. So they kind of have pain kind of in this area, a little bit on the side. Rarely they can have pain in the buttock area. Most of the time if you have pain in the buttock area, the vast majority that's probably not coming from the hip, it's coming from the back. So pain in the front or the side is typical of hip impingement. You can have pain with any activity. Once it progresses, one of the main things people complain about is sitting pain, because when you're sitting, that ball is kind of brought right up against that socket, and it's once you get a labral tear that's progressed enough, then it causes pain. So that's ultimately one of the things that drives people to get surgery is the sitting pains. Obviously, most of us sit at least a decent part of the day. The treatment, it depends. I mean, for the most part, we start with physical therapy. Therapy does nothing for the impingement, does nothing for the tear itself. What it tries to do is strengthen the muscles around the hip and the back to take pressure off that area. So it tries as best it can to take some tilt out of the pelvis so you're not pinching as much. It tends to work better for females who have lesser degree of deformities, because males typically have these bigger bumps on the ball, part of the ball and socket. So it tends not to work as well for males, but patients with less severe deformities, it tends to work for. If that does not help, realistically, it's either just try to deal with the pain as best the patient can with anti-inflammatories and activity modification, or, I'll say most of my patient population doesn't really enjoy the activity modification. And so then you're discussing surgery, which is arthroscopic with small little incisions. And what we do is we fix the labrum back down to the socket, and then we shave the bone down to make it, instead of an oval shape, make it a round shape. So everything is congruent and everything can I guess, rotate smoothly together.
Thank you for that demonstration, Dr. Postma. That's pretty interesting. The hip is an interesting joint. I can relate because I had a hip injury not too long ago, and I can attest that physical therapy was, it was the first step taken, and it definitely did improve my condition. So I'm much better now thanks to that. So thank you, Dr. Postma. If you're just joining us now, thank you for tuning in. My name is Mishan Carter, and today I am joined by several of our orthopedic surgeons, Dr. William Postma, Dr. Brent Weasel, and Dr. Ryan Murray. I'm sorry. We have already heard from our providers about meniscus tears and injuries, ACL injuries, hip and shoulder injuries as well, but we have more to talk about. If you have any questions, share those in the comment section below. Feel free to share this broadcast with your friends and give us a like to let us know that you're here and that you're watching. So we have more to talk about. So let's dive into some more of our questions. So I'd like to talk to Dr. Murray about how these injuries relate or show up in adolescents. So what are some of the common sports injuries in children and adolescents that you see? You're on mute, Dr. Murray.
I try to stay quiet, and that's what I get. The vast majority of sports-related injuries in children and adolescents are typically, chronic overuse type injuries that particularly as a kid goes through a period of rapid growth in adolescence. Some of their muscles and tendons can be tight and put stress on their insertion sites on the bone, and a lot of these manifest as sort of childhood or adolescent related overuse injuries, and a lot of those can be managed non-operatively. However, particularly as you get older into adolescence and kids are participating in competitive sports at a pretty high rate nowadays, almost on a year-round basis, the rate of more significant injuries like ACL tears and patellar instability events or shoulder dislocations is increasing over time, and that's likely in part due to how competitive youth and adolescent sports have become, and how much time they're spending playing those sports. And in addition, there's probably a slightly higher rate of fractures in general, such as, collarbone fractures or fractures about the elbow or knee or ankle that you wouldn't necessarily see in an adult because they would probably have more of a soft tissue manifestation.
Yeah. Now for parents, if their child has sustained an injury, at what point should they consult a pediatric orthopedic surgeon?
I get that question a lot from friends of mine and family members. They call and say, "Do I need to bring the kid in to see you?" And really, as the three of us are all parents, I think you can recognize that you know your kid the best, and if they're not behaving in such a way that is normal for them. No one ever has wasted my time bringing their kid in to get checked out after a sports-related injury. If you worry about the kid, then there's a reason for it, and it'll give you peace of mind to get them checked out. I mean, certainly, like sort of hard and fast rules. If the limb or it doesn't look right, it looks kind of deformed or swollen, or they don't have full range of motion, or they can't weight bear on their extremity, that's certainly a reason to bring someone in. Even if you think they're probably okay, maybe that's a reason to bring them in objectively. But otherwise, certainly, if it'll bring you peace of mind to have a third party check them out, I never think it's too much to do that. So
that's great to hear. So along those lines, what would you consider a pediatric sports injury? Is there any difference in injuries that are seen in adults versus those seen in children?
I mean, pediatric patients are largely defined by their age, and the injuries, I think, that are unique to pediatric patients depend on whether or not they're still growing. So females typically grow to around the age of 14, and males typically grow to about the age of 16. And in patients younger than those ages, they can have injuries specific to sort of the pediatric population in terms of growth plate related injuries, fractures about the growth plate, or some unique, sports injuries. And then, generally adolescent patients who are older than those ages or kind of look like an adult, if you will. I certainly see some adolescent patients that are taller than I am coming to the office. Their injuries manifest generally as adult type injuries. However, sometimes you have to take a second and realize that they still are kids, and mentally and both mentally and physically, you need to kind of have a little bit of different approach. But typically, growing children, I would consider pediatric sports injuries.
Okay, thank you. Also, just a follow up for you, Dr. Murray. What is a pediatric ACL injury, and what type of treatment is available for that?
So I would consider pediatric ACL injuries to be an ACL injury in someone who's still growing, meaning they have an open growth plate. And you can tell that based on their x-ray, you can tell that based on their MRI scan, or you can actually tell someone's skeletal age based on an x-ray of their hand. And I use these things when someone is still growing, to consider how to treat an ACL injury. The ACL injury, like Dr. Postma showed before, is fairly similar mechanism, oftentimes non-contact pivoting type mechanism of injury, where the knee temporarily shifts out of place and that tears the ligament. And when the ACL is torn, folks can have persistent instability of their knee. And treatment for ACL injuries, as Dr. Postma went through before, is oftentimes surgical. And it may seem counterintuitive, but in my experience, it's actually much more difficult to treat a younger patient non-operatively. And that's simply because the ACL doesn't heal based on the environment it's in and the way it tears. And then getting a child or adolescent to modify their activities or limit the things they do, or do certain exercises on a routine basis, as you can imagine, is somewhat more challenging than having a responsible adult asking them to not just kind of do high risk activities. So the surgical treatment for ACL tears in children and adolescents depends on how much growth they have remaining. The problem with treating ACL tears, and what gives some surgeons pause in treating ACL tears in children and adolescents, is the ACL is very close to the growth plates on both the femur and the tibial side. And in drilling the sockets you do for traditional ACL reconstruction, you have to go through those growth plates, or where those growth plates once were. And so if a child has a lot of growth remaining, intuitively you can realize you may not want to drill through their growth plates, or you may want to consider alternative techniques. And so there are different techniques where you completely avoid the growth plates and don't drill any tunnels, or techniques where you drill tunnels near a growth plate but avoid them using different approaches. And the thought of how much growth someone has remaining goes into planning, the approach to surgery, the graft you would choose, and what sport they want to get back to as well. So largely the injury is similar to the adult population, and the treatment is generally similar in that it is oftentimes surgical. However, there are some nuances in the approach, and so I use a lot of factors to determine how much growth someone has remaining, to consider which approach would be the best for each patient.
All right. Thank you very much, Dr. Murray. Turning back to Dr. Weasel, could you tell us about shoulder dislocation? What is that and how it's typically treated? I think you're on mute.
We don't learn very well from our mistakes, so at least not on the video. We do in surgery. We talked a little bit about that earlier, and Ryan touched on the difference between how you treat shoulder dislocations in adults and kids. But basically, a shoulder dislocation is when the ball and socket part of the shoulder joint comes apart. So just like Will showed you the ball and socket part of the hip joint, shoulder is the same thing, but as we mentioned earlier, the bones don't wrap around the shoulder nearly as much as they do in the hip. So in the hip, the problem that we're dealing with a lot of the times is that there's too much bone and it's causing the hip not to move and cause problems. In the shoulder, it's the opposite. There's not very much bone, and so you worry about the shoulder coming in and out of place. And when that happens, you'll typically tear some of that same labral tissue that we talk about in the hip, but instead of tearing it because you're mashing it between two pieces, you tear it because you're pulling the joint apart. And we know that sometimes that heals back in where it's supposed to, in which case the shoulder does fairly well. A lot of times, if it does heal, it doesn't heal in quite the right place, so the shoulder will continually come out of place. And then just like a knee, if the shoulder is coming out of place, just like a knee without an ACL, you'll develop arthritis. And so this tends to be the one time where actually being younger is a disadvantage. So most of the time when you're younger, you heal much better. In the case of shoulder dislocations, the younger you are, the more likely you are to have it happen again. And so a lot of times we'll see in patients under 20, partially because of what Ryan touched on before, and that they're much more active, they will have recurrent instability and require some surgery to fix it. Whereas when you get older, that's much less likely, and the shoulder actually tends to stiffen up. And if it does come to surgery, most of the time we can fix a shoulder dislocation with an arthroscopic procedure, where we go in there with the camera and special instruments, bring that torn tissue back up on the front of the socket, and that'll help keep the shoulder in place. But it's, I think one of the interesting things you see with the three of us talking here, and I think one of the advantages of sort of our sports shoulder group that we have here at MedStar Georgetown, is that a lot of this stuff is the same. So the shoulder is very similar to the hip, but with some very sort of different specifics. And so we sort of share a lot of knowledge and techniques back and forth between the three of us. And I think it works well because, we each have very different expertise, but then there's some overlap. And so it's not uncommon for two of us will actually operate together. And, we certainly talk about cases all the time, and there may be something Will's doing in the hip, where he says, hey, I'm showing him a problem. I don't know what to do with it. He said, well, we're doing it this way in the hip. And it's something that I wouldn't have thought of, because that's not a joint that I operate on, and vice versa. So I think that's one of the advantages that we see of our group. And it's one of the things we're sort of very proud of the relationship we have with each other and the way we're able to help each other, which lets us help the patients better.
I think that's a really good point. A good point for patients to keep in mind of the team approach that we have available at MedStar Georgetown. So thank you very much, Dr. Weasel. At this time, I'd like to talk about physical therapy and those options. So what role, Dr. Postma, what role does physical therapy play in sports or shoulder injuries?
Notice I unmuted myself as opposed to my two partners. Physical therapy, honestly, most things we start off with physical therapy. There are there's some exceptions. Obviously, with fractures and things like that, we don't really, most of the time that's going to be a surgical thing. With ACLs, we talked about, most of the time that's a surgical thing, although physical therapy plays a huge role in that, both pre-op as well as post-op. With non-operative things, physical therapy is very important, but with surgery, I would say most of my surgery, the surgery is 50% of it, and the physical therapy afterwards is 50% of it. And so we do have therapists we recommend. At Georgetown, we actually have a great physical therapy group, I will say. Pretty much all of them are really, really good. But if you end up with the wrong therapist, whether they're not aggressive enough or too aggressive, or they don't really know the body part that you're discussing, it can change the whole outcome, whether you're talking about the non-operative management of something or the operative management of something. So I'm very particular about therapy and who I send them to. And when we all have protocols that we follow after surgery, but you still need someone to execute that protocol.
Absolutely. All right, Dr. Postma, just to follow up, is there anything preventative that patients can do to, prevent a sports or shoulder injury? Anything that we can do ahead of time, or, possibly some stretches, some type of activities that we could do to prevent those from happening in the first place?
I'll let Dr. Murray and Dr. Weasel talk about the shoulder. They do much more shoulder than I do. There are, as far as the knee, and again, this might be a better question for Dr. Murray since he deals more with pediatric ACLs than I do, but there are ACL prevention programs you can do. They have been shown to be somewhat effective, maybe not super effective, but somewhat effective, particularly for the female. athlete. Some for the male athlete, but the female is much more prone to ACL injuries. But I'll defer to Ryan or Brent to talk about the shoulder aspect of it. Or Ryan, if you want to talk about the ACL for pediatrics.
Yeah, there is a program for soccer, and it can be applied to all sports, but it's been studied in soccer called FIFA 11, which is an ACL injury prevention program, working on different neuromuscular training and strengthening exercises that a coach could take a soccer team through, and it has been shown to be relatively effective. And I know a lot of places locally are doing that, soccer clubs and things like that. And I'll let Brent talk about preventing injuries in the shoulder.
Yeah, I mean, I think for the shoulder, a little bit like how we talked about treating rotator cuff tears or injuries by strengthening the rotator cuff in the front and the back. That's sort of like brushing your teeth for the shoulders. And so there's some very effective exercises to strengthen those using some exercise bands. And there's a program available on the American Academy of Orthopaedic Surgeons. Their patient exercise website's called orthoinfo.org. And if you go on there, there's a great rotator cuff strengthening program. And then when we talk about sort of sport-specific shoulder injuries, a lot of the injuries we'll see are in throwing athletes, and they have some specific pathology where because when they throw, they've got to slow their arm down, so the tissue in the back of the shoulder gets thick and they get stiff back there, which can cause a lot of problems. And so, it's certainly been shown that for throwing athletes or overhead athletes like tennis players, it makes a huge difference if they do some stretching exercises to keep the back of that shoulder loose.
All right. Well, thank you all, doctors, for your response to that question and delving deeper into just some preventative measures that we can take. At this time, I'd like to talk about cartilage injuries. So Dr. Murray, could you tell us more about what a cartilage injury is in a pediatric patient, when this would happen, and any possible treatment options?
So when we're talking about cartilage injuries, we're talking about articular cartilage, which is the smooth cartilages at the end of your bone. So it's at the end of your femur bone, around the knee or the top of the tibia bone, or like Dr. Postma talked about, around the hip. It's part of that ball and socket is lined with articular cartilage, same in the shoulder. And when you're talking about cartilage injuries, anyone can get a cartilage injury associated with a traumatic event. Probably the most common one we see is if someone has a kneecap dislocation, when the kneecap slides out of place, or when it comes back in, a piece of cartilage can be kind of torn or injured in that way, and that cartilage can actually become completely loose. And that can be problematic, having a loose piece of cartilage in the knee, not only from the absence of it where it's supposed to be, but also from the mechanical nature of having a piece of cartilage in the knee. You can imagine it like a rock or pebble in your shoe being a problem. There is a specific cartilage pathology that most commonly affects kids around their knee. You can also get it in the elbow or the ankle, called osteochondritis dissecans, which I essentially think of as a stress fracture of the bone underneath the cartilage, largely a genetic predisposition, but also probably related to some repetitive microtrauma, where you get this kind of injury in the bone underneath the cartilage, and then that cartilage can become injured or loose as a result of that. And depending on how much growth the child has remaining or the extent to which the cartilage or bone is loose, the treatment's a little different. So a lot of them actually you can treat non-operatively if someone's still growing, because they have a lot of blood flow to their knee, and that will allow them to heal it if you modify their activities for a period of time. However, if the cartilage is, much like the case of a traumatic cartilage injury, if the cartilage is loose or displaced, you have to put it back to where it came from. Or in some cases, when these things have gone on for a while and been unrecognized or neglected, something Dr. Postman and I do a fair amount is cartilage restoration surgery, which is where you are either repairing or in restoration situations, replacing the cartilage with either cartilage from somewhere else in the person's knee, or other techniques to use donor cartilage to replace the cartilage that was lost.
All right, thank you, Dr. Murray. And as we wrap up, I'd like to present this last question to the panel. Is there anything else that you'd like to share for our patients and our audience out there? Anything, any important takeaways that you'd like to share with our audience?
I think I'm the only one off mute right now, so I just start by echoing something Brent said earlier, which is our group, the three of us have, we cover the whole spectrum of pathology related to sports injuries, all age ranges and all body parts, and we really work well as a team. And I see a lot of adolescent patients who have hip problems, but I oftentimes refer them to my partner who does all the hip surgery around town, because he's certainly very good at it. And the same goes for patients that need shoulder replacement surgery. I know Brent does a ton of it and does it really well. So rather than any of us dabbling in areas that we don't have a lot of experience with, we actually divide up what we do to give patients the best outcomes. And so I think it works really well.
Yeah, and I'll echo that. I mean, I think that's what sets us apart, is that most of the time you get another practice and they're, kind of jack of all trades, where they dabble a little bit in everything. It's better for the patients in general to go to somebody that just does or specializes in their areas. I take my own kids to see Dr. Murray. Brent does as well. But Ryan does a great job outside of the pediatric group as well. And he also operates on adults and does a great job in that population as well. So I think it's nice what we have, and it's nice that we all get along. It's nice that we all sort of share and work as a team.
Yeah, I'll echo the same thing. I think we have a great team, and I really enjoy working with these guys. I think we work really well together. And I think you sort of asked earlier on, when should I bring somebody in, or when should I, in terms of children, or when should I come in? And the answer is, if you're concerned and it hurts, or even if you're worried about it, come in. You're not wasting our time. We're happy to help you, and that's what we're here for.
Great. Thank you very much. I think that was well said. It's great to know, as a patient, former patient of needing that hip recovery, I can attest to the fact that it's great to have a team approach, and it does lead to good outcomes. So that wraps up our broadcast. Thank you to everyone for tuning in and joining us on the broadcast. Thanks to all of our physicians, our panel, Dr. Brent Weasel, Dr. Ryan Murray, and Dr. William Postma. Thank you for your time. If you'd like more information or to schedule a consultation with one of our experts, please call 202-444-8766, or you can visit our website, medstarhealth.org/MGUH ortho. We're going to share that information as well in the comments for you. All right, so thanks again, and we'll see you next time. Bye.
You.
Thanks.
Thank you.